Thank you, Dan. So this is the last talk of the session, and for those who have been here for the earlier talks, it's going to be a little bit of a refresher course. You might have heard you're going to see the ABC News clip again, just to warn you. But for those who are first time here, we're going to talk about this process of angiogenesis, which is the growth of new blood vessels in our body. So it's a natural bodily process. And in these degenerative diseases of the brain, we believe over time, this is healthy tissue in the brain. These are blood vessels, capillaries, that nourish the neurons in our brain. Over time, inexorably in these diseases, you get loss of blood perfusion. You get less blood supply to the brain. Choking off in Parkinson's disease, choking off the dopamine-producing cells, more globally in Alzheimer's. So I'm going to be talking at this talk about a drug which is the most potent stimulator of angiogenesis in our bodies, and how we use that drug. I'll first talk about some of the clinical studies that have been successful. This is a topical use of the drug in wound healing. I'll then go into how we've used it in the heart in a phase 2 US FDA clinical trials. And then I'll spend the rest of the time talking about the brain disorders, which is not as far along, but I think have great promise. As Dan mentioned, we're treating unmet medical needs. We think these are big opportunities, and most importantly, we are really, in my mind, attacking the root cause of these diseases. That lack of blood flow initiates all the diseases I'm going to be talking about. And by reversing that, we're actually reversing the root cause of the disease. So it's a disease-modifying type of treatment. Okay, so let's look at topical angiogenesis. This shows wound healing. Let's think of that as a skin wound. You're looking underneath a scab. You can see these tiny little vessels there, ribbon-like vessels. That's angiogenesis in work. There are new blood vessels that have appeared, stimulated by a number of growth factors, including the one I'll be talking about, FGF1. That repairs the skin. It also repairs neurons that might be there. And I'll show you in wound healing indications in diabetics that actually accelerates the closing of these nasty diabetic foot ulcers. And we have phase 2 clinical trial data on that. I've shown this slide before, but angiogenesis, being a normal bodily process, also can get out of whack in a number of diseases. 75 human diseases are characterized by either insufficient angiogenesis or excessive angiogenesis. We'll talk about insufficient with stroke. Stroke and heart disease accounting for more than 50% of all deaths in the world. We'll talk about diabetic foot ulcers. We won't talk about excessive angiogenesis at all. Like, for example, neovascularization in the retina can lead to blindness. Cancer needs excessive angiogenesis for the tumor cells to divide. What we will talk about are these indications: diabetic foot ulcers, wound healing, coronary artery disease, injecting it directly into the heart, and then spend more time on these cerebral aspects of our drug, looking at stroke treatment and treatment of these different neurodegenerative diseases. Okay, for those of you who have been here, you know what our drug is. It's FGF1, a natural growth factor, a very potent stimulator of new blood vessel growth. This is a structure shown here. It's just a simple protein. It's like insulin or growth hormone made in our bodies, but it's only made when you need it. It's only made when you have a problem. So if you inject FGF1 into normal tissue, nothing will happen. So only when you cut yourself, only when you have a lesion in your heart will FGF1 be made. So it's really in response to injury that FGF1 works. Now, I was involved in purifying this back when I was at Washington University in St. Louis from about 1,000 cow brains. We've mashed up a lot of cow brains, and got a little bit, and we did the structure. And actually, Merck had the patent on this a long time ago. It's since expired. If you heard Dan's talk, we're trying to get market exclusivity now, be first to market for our FGF1 and a number of these indications I'll be talking about. Okay, let's show you some success we've had using this angiogenic compound to treat diabetic foot ulcers. This is a wound healing indication. Topically apply the FGF1 to these ulcers. All right, there's a diabetic foot ulcer right there. It's a nasty chronic wound. Diabetics really can't feel very well, so they have neuropathy in their feet. They have poor vascularization, poor blood vessel development, poor perfusion in their feet. So they get these sores that don't heal, that can last for years. So we've treated these ulcers with FGF1, just placing FGF1 in the wound bed here for a period. I'll show you just one study we've done for 5 months. So diabetic foot ulcers treated for 5 months. We were able to completely heal 100% of those ulcers. Before I show you that, as a scientist, I've got to show you an animal study. So we can get diabetic mice that have wound healing issues as well. We give them a wound, experimental wound, and then treat these guys with FGF1 and these guys with placebo. At day 15, you can see clearly that the FGF1 treated wounds heal much more rapidly. So the same type of process went on in people in a phase 2 clinical trial. This data here were open diabetic wounds were treated for a period of about 5 months. This is the end of the trial. Those treated with FGF1, 100% had healed, versus placebo, about 35% still remain open. Importantly, at 8 weeks, this 8 weeks is about here, about 57% of the ulcers had closed that were treated with FGF1, where none, 0%, had closed with the placebo. So that's a very remarkable disease-modifying type of finding. And let me just show you what a diabetic foot ulcer looks like. This is before treatment starts. This is 3 weeks before treatment starts. These are similar size ulcers that we're going to treat with FGF1 or with a placebo dose. And you can clearly see the FGF1 treated ulcers are healed by week 12. The untreated ulcers are still open at the end of the clinical trial. So this is definitely a major unmet medical need. Others have said that FGF1 could be a game-changing wound healing drug that will impact the market. So we're repeating, we have a new manufacturer of FGF1, so we're going to be repeating that phase 2 trial with drug that we've newly made, and we think we'll see the same result, and then hopefully, depending on whether the FDA gives us a breakthrough designation, whether we'll have to do a phase 3 trial or whether we can seek approval for this unmet medical need with phase 2 data. Okay, another indication which has been in phase 2 is heart disease, coronary heart disease. We're treating mainly the microvasculature, but we've seen actually if, say this is a major coronary artery, that can get blocked fully. If we inject the FGF1 right there, we do see these tiny little vessels kind of growing around it. So it's kind of like a bio-bypass, we call it, not a normal bypass. So we can grow lots of microvasculature, as I'll show you in the next slide, but we also can bypass these major arteries. So it's actually a dual effect. So when we do our clinical trial, we inject close to where a major blockage is, as well as where there might be minor blockages. This shows what happens when you look at the microvasculature. So this is an angiogram. Coronary artery is filling with a dye. You then use kind of an X-ray source to image this. This person has severe coronary artery disease. This part of the heart muscle is not being at all perfused with blood. So this would be hypoxic. This would be ischemic, or another word to describe it. The heart muscle is not contracting because of lack of blood perfusion. If you treat with FGF1 and then wait 12 weeks and do the same angiogram, you can see all this new microvasculature filling with blood, supplying this region of the ischemic heart with blood perfusion. So these patients that have been treated after 12 weeks, they have less chest pain. You put them on a bicycle or a treadmill, they do better. And their injection fraction, how forceful blood is coming out of their heart, improves. Okay, for those of you who have seen this is one more time. This is a ABC News clip from the clinical trial I was supervising where we injected FGF1 directly into the hearts of patients with severe coronary artery disease. One of the sites, Cincinnati site, patients did very well, and ABC News went down there to do a story on them.
Arteries, his pain is gone.
I really feel great.
Duke was one of the first heart patients in the country to be treated with a protein actually capable of growing brand new arteries. The genetically engineered protein is injected directly into the heart. Within days, a network of new vessels begins to grow around the blockage, increasing the blood supply. Dr. Lynn Wagner showed us the changes in one patient's heart.
In this particular case, we see a small, narrow main artery and not very many secondary and tertiary arteries. This is after the treatment. What we're now seeing is new blood vessels growing here off the end of this artery.
And the patients themselves?
Symptomatically, they're improved within a couple of weeks of the treatment.
Just ask Constance Donnelly.
Oh, I feel wonderful. I've never felt so good in the last 5 years.
But doctors already see potential in other cases where the blood supply needs a boost, such as strokes and diabetes.
Okay, and as has been mentioned before, this woman, Constance Donnelly, was in the low dosing group. We had 3 dosing groups. She was in the lowest dosing group. She responded the best out of anyone. We treated about 29 patients in that clinical trial. She was in a wheelchair before she was treated. She was up and about, and she had a life expectancy of less than 2 years when we treated her. She lived for another 10 years and got to spend that. 12 years? Okay. Okay, so that was our heart trial. The next trial we'll be doing, we won't be directly injecting it into heart muscle. We'll be using a catheter, kind of goes up into the aorta through the aortic arch, so right into the center of the heart where we can then advance it to the heart muscle and inject directly into heart muscle. So we think that'll be a better approach than what you saw on that ABC News clip. Okay, so let's move up into the brain, looking at stroke and neurodegenerative diseases. I've shown you this slide before in previous talks, but the brain is an incredibly vascularized organ. We have billions and billions of neurons in our brain, and they have a high metabolic demand. They need lots of glucose. Probably 30% of the glucose we take in goes to the brain. Needs lots of oxygen, and also very importantly, the brain generates lots, like all our bodily cells, generates lots of metabolic waste. So we've got to remove that as well. We think in some of the neurodegenerative diseases I'll be talking about, things can accumulate if you have a defective blood flow in the brain. In Alzheimer's, beta amyloid plaque accumulates. We think that's a vascular cause. And I'll show you in Parkinson's disease, another toxic protein accumulates in the brains of patients with Parkinson's disease. We believe if we can reestablish the vascularization in those diseases, we can not only perfuse neurons and get them to grow better, but we can remove toxic waste substances from the brain. So in the brain, a very important structural unit is called the neurovascular unit. This is simply the smallest vessels in our brain, the capillaries right here. These are the smallest vessels in our brain interacting with neurons. So every neuron in our brain basically has a dedicated capillary to supply it with nutrients and to remove waste products. These capillaries can get damaged. They can become atherosclerotic, so they can fill up with plaque. I'll show you in multiple sclerosis, they've become leaky, so they actually can leak nasty things that affect the neurons in multiple sclerosis. But one can imagine if these get blocked, become dysfunctional, or simply disappear, these neurons are going to suffer. One other concept in the brain is that angiogenesis, the growth of new blood vessels, is coupled to neurogenesis. So neurogenesis is a production of new neurons from stem cells in our brains. We all have stem cells in our brains. It wasn't really appreciated 15 years ago. People thought we were born with the number of nerve cells in our brains that we ever would have, and that's certainly not the case. And I'll show you a video in a second where 80-year-olds have the same number of stem cells as a 18-year-old. The difference is with 80-year-olds, there's not as much blood perfusion in their brains, and therefore they don't get the neuronal regeneration that a younger person can get. Standing on your head. Exercise helps. Exercise helps. So yoga. Yeah, yoga. I'm not sure blood flow into the brain, but when you exercise, you actually increase angiogenesis in your brain, and a lot of patients benefit from that, especially with Parkinson's disease. Yeah. So let me tell you about the study that I was mentioning. This is in normal people. This was done at Columbia University Medical School. Normal people, young people, old people. Let's look at the stem cells and the memory. They're looking in the hippocampus, pretty much the memory part of the brain. And this study addressed why do their brains work less well as they age? So this is not a disease, this is just aging. But what they concluded really goes along with what we're going to show you, that we believe in these diseases, these neurodegenerative diseases. The same process is going on. This is the Columbia study. Stem cells, this brain is mainly stem cells. Older people remain as many new stem cells as younger ones. In the aging brain, there's reduced blood flow. Brains have less active neurons. So we know this older brains are as active as younger brains. So the researchers at Columbia suggested that it may be possible to combat cognitive decline. So that's exactly what we're trying to do with our angiogenesis treatment in these diseases. We're not looking at it yet in aging, but in these neurodegenerative diseases that I'll talk about, we believe it's a lack of blood flow, either globally or to very selected regions of the brain, which initiates and causes these diseases to progress. Just one slide, just to summarize again what that video showed. Stem cells, brain stem cells. We all have them in our brains now. Presumably the older we are, the less active they are. But you need those stem cells to form, mature into new neurons, and also all these supporting neurons. So you need all these cells in the brain to have healthy brain tissue. And in, for example, Parkinson's disease, these would be the dopamine-producing neurons. And so you need an active pool of stem cells dividing into dopamine-producing neurons to counteract the root cause of that disease. So first I'll talk about stroke studies, and then I'll talk about some of the neurodegenerative diseases and how we think this drug we're developing has potential. Stroke it can be of two types. 75% of them are due to blockages of an artery, either leading to the brain or in the brain. 15% are due to a rupture. And as we all know, stroke can produce disastrous results. Here's a clot in the carotid artery, leading to this large infarcted area, which can affect function, memory, speech, all kinds of things. So we have tested our FGF1 in an animal model of stroke. So you can do the same thing to a poor rat. You can give it a stroke and then test various drugs to see if you can either diminish this area and repopulate this area with functional brain tissue. So this is an animal model in rats. We give them a stroke. These are brain slices. You can see here's a stroke right here. This is white infarcted. These animals don't do well. They're not moving around at all in their cages. Treat them for 3 weeks with FGF1. You can see the stroke volume is down. They're moving around their cages better motor skills. And I think here you can see the repopulation of the area of the brain with new neurons. This is through, again, the process of angiogenesis and neurogenesis in these animals. Traumatic brain injury. If you look at, this is an actual person, human with a traumatic brain injury, looking at an electron micrograph of brain tissue. This is normal tissue. These are vessels, blood vessels. This is larger vessels, smaller vessels. After a traumatic brain injury, you can see the dramatic results, effects on the vasculature. You can see these shrinking down. This becomes disordered. And neurons in this part of the brain, even with a healed traumatic brain injury, are not doing as well. And there's so long-term sequela of a traumatic brain injury. We can look at that in animals. So giving a rodent an insult, 24 hours later they develop a traumatic brain injury. If you treat that animal for 3 weeks with FGF1, again, like we saw in stroke, you get nice healing of that lesion. Again, this would be through the process of angiogenesis coupled to neurogenesis, okay? And if we look in that traumatic brain injury, this is the vasculature. So this is a normal animal. Healthy capillaries, you can see there, they're ordered, they're functional. After injury, depletion of the vessels. If you then treat with FGF1, this is right here, that's FGF1 treatment. Compare that to placebo treated. Both grow back the vessels, both grow back capillaries, but compared to normal, this is tangled, dysfunctional. These animals did not perform as well on their testing as those treated with FGF1. So restoring normal type vasculature to an animal with a traumatic brain injury. Sure.
When do you anticipate the human trials for the stroke and the traumatic brain injury? You're just doing the rats right now.
Right, so we have the animal data. We have the toxicity data to support that, so we could start that probably at the end of this year or the beginning of next year. And these first trials are always very small trials. We probably have like 20 people or so just to prove the concept, because this has never been done in people. Okay, so our three main degenerative diseases of the brain include Alzheimer's, Parkinson's, and MS. And I'll try to give you some supporting data why we think FGF1, this angiogenic growth factor, is an attractive candidate to test in each one of these diseases. This is the brain, healthy brain, and one with advanced Alzheimer's. You can see gross depletion of brain structures, neurons, blood vessels. And so this is advanced Alzheimer's. You want to sit down?
I didn't want to.
No, come on, sit down. That's all right. or Vika. Some characteristics of Alzheimer's, we see these, as I mentioned, the buildup of toxic proteins, these amyloid plaques. These are toxic to neurons. So, and again, we believe these are hanging around due to a lack of blood perfusion in the Alzheimer's brain. Also in the Alzheimer's brain, you see less metabolic activity. This is a normal brain. PET scans show how much glucose they're burning, basically normal metabolic activity. Mild cognitive Alzheimer's disease, so very reduced metabolic activity. So how does blood flow work in this disease? Well, we haven't tried an animal study. We haven't gone into humans yet, but at McGill University in Canada, this is in Montreal, Canada, they did a remarkably large study looking at over 1,000 patients that had Alzheimer's disease. And they traced them through their progression from mild disease to late stage disease. They examined over 78 regions of the brain with almost 10,000 brain images that were looked at. And these are the 5 things they followed in these 1,000 patients over time. They looked, when does beta amyloid start accumulating in these patients' brains? When do they start having metabolic problems in their brain? Importantly for us, when do they start showing blood perfusion defects in their brain? When do they have cognitive deficits? When does the structural aspects of the brain begin to fall apart? And the results, which were published about 2 years ago, I think are quite remarkable. This is a busy slide, but let me point out the main aspect. The very first thing they saw in those Alzheimer patients was an abnormality in this right here, which is vascular abnormalities, preceding red, which is beta amyloid deposition, preceding memory loss. So vascular perfusion deficits occur first. So we're hopeful that if we can treat a vascular perfusion deficit with an FGF1 type of angiogenic agent, and we treat them early enough, we may be able to try to overcome some of these later sequela of Alzheimer's disease. Let me turn to Parkinson's disease. We have an IND on file now with the FDA to treat patients with Parkinson's with FGF1 intravenously. FGF1 does get across the blood-brain barrier. About 4% of it can get across, so we're hopeful. Previous studies have injected factors directly into the brain, which is dangerous. I mean, and infections can result. So we're glad that we can inject this intravenously. With Parkinson's, we're dealing with a very tiny region of the brain called the substantia nigra. So it's not a global brain disorder like Alzheimer's, but a very small, in fact, there's only 500,000 neurons here. 500,000 neurons out of the billions are affected in Parkinson's disease. These are the dopamine producing neurons, normal dopamine neuron, normal movement. Parkinson affected neurons, less dopamine pre-produced, less movement disorders. So if you look at blood perfusion in Parkinson's disease, what do you see? You can use imaging technology to look directly into the deep areas of the brain, into the substantia nigra region of the brain, and see, is there any perfusion, blood perfusion abnormalities? So this is regional blood perfusion by functional MRI, giving you real-time blood perfusion in these patients. A healthy 21-year-old has maximal blood perfusion in blue in that region of the brain which is affected in Parkinson's. A healthy 65-year-old, as that video we just watched, blood perfusion is down, but these people are still healthy, maybe forgetful where their keys are or something of that nature. But in Parkinson's disease, almost a 50% decline in this regional blood perfusion. So again, going along with our concept that a decline in blood perfusion in this very selected region of the brain leads to those dopamine-producing cells becoming dysfunctional and then dying. Now, Parkinson's disease also affects non-motor regions of the brain. It's known that, for example, one of the first things that can go in Parkinson's is smell. Speech can be affected. And there's also cognitive issues in Parkinson's disease. So using that same imaging technology, you can say, are these other deficits in Parkinson's due to a lack of blood perfusion? So this is a scan showing perfusion defects in a patient with Parkinson's disease and dementia. And perfusion is, this is the entire brain, it's showing really the cortex, the outer regions of our brain. Blue is normal blood flow, yellow is decreased blood flow, and then red is severely, significantly decreased blood flow. So in this patient with Parkinson's, we see a loss of blood flow, probably not only, we're not looking at it in this diagram, not only in their dopamine-producing region, but also in this region associated with cognitive function, executive functioning, memory. We think if we treat a patient with FGF1 with this type of disorder, the FGF1 is going to get to these areas as well. And so we think we can treat not only movement complications of Parkinson's, but also these other common complications of Parkinson's disease. Now, some animal work has been done in rats and in monkeys. I'll show you that briefly. You can give mice Parkinson's disease by injecting a toxin into their brain. They produce less dopamine after toxin. Here's normal dopamine production in the rat brain. FGF1 doesn't get it back to normal, but it gets it about halfway back to normal. These rats are doing much better in their motor skill activity. I think more impressive is the gold standard for Parkinson's disease is primate monkeys who have been given Parkinson's disease. And this shows, this is a different slide than I had before, but this will work. So monkeys that are given a toxin, which selectively destroys their dopamine-producing cells, over a period of about 9 months here, this is a 9-month period, they develop all the classical symptoms, motor symptoms of Parkinson's disease. So down here, these monkeys are not doing as well. Treatment with FGF1 is started right here. This is the FGF1 treated monkeys. This is placebo treated monkeys down below there. The FGF1 treated monkeys restore to about 80% normal of their motor functioning skills. So that is definitely an efficacious response in this animal model. And this supported our IND application to the FDA. If you look in the brains of those monkeys, we want to see if this is a disease-modifying type of activity that FGF1 is doing. Clearly, it is regenerating more dopamine-producing neurons, as shown here. This is brain slices near the substantia nigra, where the dopamine-producing cells are located. No FGF1, and then new dopamine-producing neurons in that region of the brain. And finally, looking at toxic proteins, in the monkeys, you get aggregation of a protein, synuclein, which is toxic to neurons. So this are these tangles that are seen in the monkeys and patients with Parkinson's disease. FGF1 clears those toxic aggregates as shown on this panel here on the right-hand side. And you can see on the left-hand side are normal monkey brains where there's this toxic protein does not accumulate. Okay, so the FDA has asked us to do one additional animal toxicity study, which we're doing now. They want to see more data that the FGF1 doesn't cause any issues in the brain. We've never looked at it in the brain, so we're doing that now. But they have accepted our clinical trial design, which is important. We'll be having 3 ascending doses of the drug. No placebo group. All patients will receive the drug over a 6-week period. And we'll measure safety and effectiveness. And we'll follow the patients out to a year to make sure there's nothing untoward going on, looking in the eyes and doing clinical evaluations to make sure that the drug is safe. When we talk, Dan and I have talked to a lot of Parkinson's support groups, and we always show this slide, what we hope to see in this clinical trial. And we have not seen this yet, but this shows the decline of dopamine neurons in Parkinson's disease. So we start out in healthy individuals, about 500,000 dopamine-producing cells. We see as we age, we lose some of those as expected, we think due to a lack of blood perfusion. But in Parkinson's, there's this inexorable decline of the dopamine-producing cells to where you get down to here, you've lost about 60% of your dopamine-producing cells. The symptoms of Parkinson's disease begin to manifest themselves. So in the phase 1 trial we'll be treating patients at this stage of their disease. We hope through angiogenesis and neurogenesis to hopefully lift them back into this region where the symptoms could abate or be less. Okay? Give me a 5-minute warning. 5-minute warning. Okay. All right. All right. So lastly, let's talk about this last neurodegenerative diseases, multiple sclerosis. Lesions develop in the spinal cord and also in the brain in this disease. It's well known that this is caused by the body's own immune cells attacking the outer sheath of the fiber. So this is like a electrical wire, the nerves, the copper, rubber coating it. In MS, immune cells attack that sheath, expose the nerve, and this leads to the symptoms of MS. We believe this is a vascular problem, and we believe a vascular approach could affect this disease. And let me just show you two bits of evidence. In multiple sclerosis, they don't know what the cause is. It might be genetic, environmental factors, even lack of vitamin D has been postulated. This is the inside of a blood vessel from a MS, from a normal patient. You can see these are the endothelial cells that line every vessel in our body. You just want to get me off the stage so you can get back up here. That's all right. Well, that's all right. So this is a smooth, ordered surface of endothelial cells lining each of our blood vessels. MS, this is completely different. These are leaky endothelial cells. They're bumpy. They're disordered. That dysfunction is going to cause things to leak out of the blood vessels in patients with MS. And let's look at a depiction of that. This is work from not us, but other labs. So in the normal brain, we have normal, healthy blood vessels. Things stay where they're supposed to stay. Optimal blood flow is shown here. But then in MS, caused by perhaps one or more of these factors, you get leaky blood vessels in the brain or in the lesion causing multiple sclerosis. Two things happen with that. One, you get reduced blood flow, so the neurons are not getting the nourishment that they need. But second, and this gets to the etiology of MS, immune cells that normally aren't out there in the brain come out and view this as a foreign substance. This neuron is now looking foreign. And one reason for that, other things that leak out of the vessel are these toxic proteins. One is fibrinogen, which actually can coat the neuron. Fibrinogen is involved in blood clotting. It's a sticky protein, forms scabs. That actually should never be in the brain. But in MS, it gets out and coats the neuron, making it, again, look foreign to the body. So that's where this whole autoimmune attack comes in MS. So with FGF1, we know we can heal dysfunctional blood vessels. We can create new ones. So we think FGF1 is a very attractive candidate to test in MS patients. And we have an IND which has been prepared and will go in to the FDA probably within 3 months. Yes?
Just MS or many autoimmune diseases?
Just MS at this point, yeah. Yeah, there we go. Yep. So work by a number of groups. These are publications that I've found implicating vascular causes of these other neurodegenerative diseases. And certainly Lou Gehrig's disease is among them. Lots of studies from lots of different universities have shown a lack of blood flow affecting motor neuron disease, and this is Lou Gehrig disease. So we think the same thing is going on with ALS. It's just affecting different set of neurons in the brain. I showed you some data on MS, Alzheimer's we talked about, stroke, traumatic brain injury we talked about. post-traumatic stress disorder, problem with the military. They come back from active duty, a lot of traumatic stress. We think that leads to that disorder as well.
Out of curiosity, will all of these be able to be treated or be able to be given intravenously, or do you have to do some via a shot drug?
Yeah, so that's what clinical trials are about, so we don't know how that will work. We will start off with IV treatment, and we'll push that as high as we can till we see something or see a safety effect. I think only then will we then think about going directly into the brain for some of these, because they're such devastating diseases. You know, patients are willing to have these things put directly into the brain.
You talk about, you have to do daily infusion of this drug.
So every day, yeah, where the clinical trial is a 1-hour infusion.
Okay, now what are the side effects? Are you noticing any hepatic problems, renal problems, or any chronic toxic problems?
Okay, so to do a clinical trial, the FDA makes you push the dose up in animals. So only in animals have we seen these adverse events, not in people. So, okay, so at 100-fold higher doses than we're going to be using in our clinical trials, things happen. So the thyroid starts to grow. You stop the drug, it shrinks back down to normal. The animals really don't suffer from that, but it is an adverse event. At 1,000-fold higher levels, the eye, you get vessels growing in the retina, which is bad, and you also get actually overstimulation of heart vessels. Coronary vessels start growing abnormally. But that's at 1,000-fold level. Down where we're treating, we're not seeing any adverse effects in the animals. We saw none in our heart trials, none in the diabetic foot ulcers. So we think we're in a nice window of safety for these trials, especially for these diseases. I mean, if you're not worrying too much about your thyroid swelling up a bit if you're getting benefit for these neurodegenerative diseases. Yeah.
You're saying an infusion. Is this general infusion, or I'm thinking of the blood-brain barrier? How are you getting?
Right. So in our clinical trial, we're going to be using what's called a PICC line. A PICC line is indwelling catheter that goes right to your vena cava. So the drug will be released right at your vena cava, and from animal studies, we know about 4% of that will cross your blood-brain barrier and get in. And in the animal studies, the drug was administered IV, and it works there. We don't know in humans. That's why we're doing these clinical trials. We only can predict what we see in animals, and we want to start at a safe dose that won't harm a patient getting the drug.
You said for ulcers, it was topical, like a cream?
Yep, it's topical like a cream.
And for the heart study, how was it?
That's just a liquid solution injected into the heart. And these indications are similar to the heart. It'll be a liquid solution, but put into this indwelling line that'll be in the patients. Right, so we start at a 1x dose. We treat all the patients for 6 weeks. We go to a safety committee, and then we're going to go to 3x the dose, and then maybe 6x the dose. So gradual, but we have to make sure it's safe at each dose before we go to the next one. Yes?
How do we know that on the long-term follow-up that we're not going to increase the chance of cancer over time?
I'm sorry, increase the... Right. So we worry about cancer quite a bit because this is a potent growth factor. We know tumors like additional blood vessels to grow, but so we look at that very, very carefully. Let me just give you a few points. FGF1 has never been shown to cause a tumor in an animal model. In all our clinical trials, we look very carefully at tumor markers. We've never seen any rise in those tumor markers. But third, we're excluding, if you have cancer, you're not going to be given our growth factor in the clinical trials. If you have a history of cancer, we're going to look very closely to make sure you don't have any active cancer, but the FDA is not allowing us to treat anyone with cancer because it could be very dangerous. Yes. Say that the blood-brain, no, not at all. In terms of, no, the vessels, one thing the vessels we form, like in that heart study, they're there 3 years later. So they're very durable. They're natural-looking vessels. They're not at all fragile. So we don't see any bleeding complications with our therapy.
Let me clarify a topic. Taking Parkinson's, one medical indication. We will probably have to do 20 different human trials at different levels of dosing, different lengths of dosing to understand which is the best. We're going to be wrong on 19. Everybody in our Parkinson's trial will cost us $100,000 to test. So a lot of you are asking very specific questions about this and this and this. We don't know those answers. We have to spend $100 million to find those answers. And in the end, the answer may be it doesn't work, or it's not safe in people. But we are taking each dosing level, each dosing group, and we are looking for how high we can dose before we have an adverse event, and what is the outcome. Everybody in this room likes chocolate. I don't know, most everybody likes chocolate. If I dose you at 200 pounds a day, you will have an adverse event. Okay? Now, before Jack continues, let me ask you a question. How many of you in this room have ever used our molecule FGF1? Raise your hand. Okay, that was a stem cell injection. My question is, how many people in this room have ever used FGF1? Please raise your hand. Each one of you in this room has used it 10,000 times in your life. Each one of you in this room has used this molecule when you heal yourself. When you're 10 years old and you're running down the street, you trip and you land on your elbow and you tear off the skin and you rupture blood vessels and you feel the tingling because the nerves are gone. Because of the trauma, your body makes FGF1 to signal your body to regenerate, to grow new blood vessels, new nerves, new skin. Has anybody in this room ever scuffed their elbow? Please raise their hand. I want to meet the rest of you. You must be have good balance. How many of you, since you did that, have had to go back and have another treatment on it? Wow. Anybody who wants an experiment on FGF, see me afterwards. I'll get a knife and cut your finger. And watch your body make FGF and heal. The process that we're talking about is these diseases are not the result of trauma, except traumatic brain injury. We believe it's the slow choking of the vascular system. There is no trauma. Because there is no trauma, your body doesn't make the FGF1 to signal the growth. Now, if we're wrong, we're wrong. But if we're right, it's a revolution. Okay? And by the way, before you do that, do not take this. You women are looking at me. I don't like it. Don't go home tonight, take a hammer, hit your husband in the head and say, honey, I'm trying to heal your brain. No trauma to the brain. I'm not authorizing that. Yes, ma'am, you have a question.
Isn't it true that the brain releases human growth hormone, HGH, every single night when we sleep? And that if we go on a fast, it stays high? And that on the third day of fasting, there's a surge in stem cells? Not to mention the cleanup of all the damaged cells in 3 days of fasting through autophagy or autophagy, eating your dead.
First of all, I like you. HGH, human growth hormone, is not FGF1, for one. Number two is, I fast, doesn't look like it, I know. But as part of my self-discipline, I'll fast 5 days, 10 days, okay? And after the third day, wow, it's amazing, okay? Fasting helps your body in many ways. This is the molecule that signals your body to regenerate. And we're looking at using it for diseases. So there's a little difference, okay?
No, there isn't. Fasting regenerates, and it'll cure diabetes in a few days by reinstituting insulin sensitivity.
Yeah.
Question for Jack. Yes, sir.
Very important question. Alzheimer's. I have 3 friends that have Alzheimer's right now. Over a period of 20 years, I've watched them right from the beginning. They put it through the computer and went downhill. It took 20 years. The important thing is smoking. When these people smoke, like these pipes, and the cardiovascular system has been clogged, flat inside. If you could remove that plaque and get those, the veins clear, you have.
We don't have anything that does, we just grow new blood vessels.
Well,
So for those of you who have rusty plumbing, we do not fix the rust. We just replumb it.
okay, could you replumb it around that?
That's what nature does. Okay. So the answer is, in that case, let me also make a
But
comment.
smoking has a direct link.
How many people have ever heard of Parkinson's disease? Okay. Where is the Parkinson's Center of America? Number 1 place to have Parkinson's, where is it?
San Joaquin Valley.
San Joaquin Valley, Fresno, Parkinson's capital. Name the 2 states. They use pesticides and insecticides all over the place. If you want to, the way they give an animal Parkinson's, is they give them an insecticide or herbicide or whatever it is. If you want to know the 2 states that have the most, Iowa and Nebraska, guess what? Insecticides, pesticides. How come dentists have a higher rate of Parkinson's than other professions?
Mercury.
Bingo. So there are many reasons that people can develop these diseases, of which we're speculating. Maybe these external factors in some form of toxicity affect the endothelial cell vascularization and corrupts it. Now, Jack did not give you his presentation on endothelial revascularization. But part of the process is while we're trying to fix all this, if there are broken vessels in there, this molecule should have those vessels repair themselves, correct, Jack?
Correct?
So there's a whole bunch of things. Now, please, people, if you came here for answers, we're the wrong people. We got more questions than you do. Okay? We're struggling to find out what those answers are. It's going to cost us $100 million in the next 3 years to find out those answers, or more. So please understand, a lot of your questions are excellent. We got them too. Okay? We're looking at the cancer markers. So far, we feel good about it. We're looking at this, we feel good about it. We got dosing levels, we feel good about it. But we don't know anything. Don't think of us as scientists, think of us as politicians. We have no idea what we're doing.
It sounds to me like the cost of treatment for a successful outcome is going to be prohibitive and probably not going to be.
I guarantee you that is not the case. We study the cost. If a person is diagnosed with Parkinson's disease, how much money is set aside to treat them for their life by the U.S. government? Medicare. Medicare. Huh? How much, man? You were guessing. No. If you get diagnosed with Parkinson's, the U.S. government sets aside $175,000 for your future care. By law. So, if somebody's going to cost the government $175,000 and we can cure them for $40,000. Now, Jack, let me do this because before you all leave tomorrow at 3:15, Vicka will be speaking on new drug diseases for women. That'll be up on stairs. That'll have a lot more of the MS and diseases primarily for women. Once again, we like women. Our mothers were women. We really think that's wonderful. On Wednesday, Jack, I'll be speaking at 10 a.m. in the bullpen on biotech investing. Yeah, right. And at 11:45, Jack will be giving a cleanup presentation, going through everything again, pretty much the same. But I make the comment, if you meet somebody, if you're having a drink, if you're talking to somebody, if you sit next to somebody and they're talking about, oh, my dividends for my REIT, you say, well, if you're dead, it doesn't matter. Go see these guys' presentation. We'd like to welcome you to the other presentation. For those of you that are interested in learning more about the pre-IPO opportunity, little red cards up here, you can fill that out and we'll chit-chat with you about it in the appropriate time. Obviously, it's for information only. Our rationale is very nice to see you again. So we want to thank you for coming. Yes, ma'am.
I just wanted to mention that you heard how much the study cost was. Basically, each patient costs $100,000, but it's not the cost of the treatment and infusion. Those patients cost us so much because we test them every single day. We test their eyes, we test their glands.
Right.
I gotta go with this.
Test them every day. It costs a lot of money. But when you take a treatment, it will be approved. So obviously, you don't test yourself every day. The test costs a lot of money.
Catch this one. For the Parkinson's trial, for everybody that's in the Parkinson's trial, they have to take, Jack, every day, a
Drug test.
drug test. When they come in, before they can get the treatment, we have to test them for alcohol, narcotics, blah, 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 blah. Why? Jack said this, I said, are you crazy? These people aren't drug dealers, they aren't crazy, whatever. You know what the neurologist said? People self-medicate. People will self-medicate because of the pain, whatever. One person who's stoned can blow the whole trial. We have to spend hundreds of dollars every time somebody comes in, every day, to make sure they're still not stoned. So Vic's point, which is excellent, by the way, is what we have to do to prove it is astronomical. For the heart patient, we have to screen 20 people, end up with one candidate. Because you know why? We need heart candidates who have no option heart disease, otherwise perfectly healthy. Try finding those people. Jack, anything else?
That's all?
Ladies and gentlemen, we thank you for coming. They're shutting down the camera. We'll be around.
Question. Several of the major